Good morning and welcome to the National Press Club, the place where news happens. I'm Jen Judson, the 115th president of the National Press Club and the land warfare reporter for Defense News. Thank you for joining us for our virtual Headliners Newsmaker with Dr. Gerald Harmon, president of the American Medical Association. Before we begin today, we would like to acknowledge that our thoughts are with soldiers defending a democracy in Europe and the men and women in the media who risk their lives to bring us that story. Please join me in a brief moment of quiet reflection for them. Thank you. We're happy to accept your questions and we'll ask as many as time permits. To submit a question, please email headliners@press.org and put AMA in the subject line. Now let's get started. The grim reality is this. We're now entering the third year of the COVID-19 pandemic that has killed nearly 1 million Americans and 5.9 million people worldwide. In the past 2 years, medical science rallied against this previously unknown enemy, creating, testing, and delivering a vaccine in record time and developing protocols to treat this evolving and peculiar disease and prevent its spread. It seems to be working. New Omicron infections in the U.S. have dropped 90% from a pandemic high just a month ago. Data compiled by Johns Hopkins University shows 84,000 new cases a day, down from 800,000 cases in mid-January. States are lifting mask mandates, kids are back in school, but we've been down this road before. We're also hearing talk of waning vaccine efficacy and the emergence of an Omicron subvariant called BA.2. Meanwhile, medical professionals must also battle misinformation, vaccine hesitancy, and the consequences of delayed medical care and increasing costs. To discuss the state of healthcare today, we are joined by Dr. Gerald Harmon, the 176th president of the American Medical Association, the nation's largest organization of doctors. Dr. Harmon is a family medicine specialist who has practiced for more than 3 decades in South Carolina. He's a clinical professor at 2 of South Carolina's medical schools and volunteers as a medical supervisor for his local school district's 23 schools. He has served in the Air Force Reserve, on active duty, and in the Air National Guard, including as chief physician for the National Guard Bureau and assistant surgeon general for the U.S. Air Force. He retired as a 2-star general. Dr. Harmon, we're delighted to welcome you to the National Press Club. The floor is yours.
Well, good morning, and thank you, Jen, for that moment of silence. We join you in expressing our heartfelt concern for the people of Ukraine and for a quick and peaceful end to this aggression. This month marks the 2-year anniversary of the first known death to COVID-19 in the United States. There isn't a single person I know who isn't worn out, frustrated, or just physically exhausted. We've experienced trauma, lockdowns, economic struggles, and at least 5 distinct viral surges. That goes double for our nation's physicians and our entire healthcare workforce, who have been under siege from the earliest days of the pandemic. We've all been hurt in different ways. Many have lost loved ones to COVID-19. The country is moving quickly towards 1 million dead from this virus. This is a heartbreaking tragedy that's unlike anything we've experienced in our lifetimes. Many have lost their jobs and the financial security that comes with that. Many have missed out on education or postponed weddings or other important celebrations. And most painfully, some have been unable to comfort dying loved ones, even to properly memorialize them at funerals. All of us have lost time with those close to us. We've had our lives totally upended. I've been a family doctor in South Carolina for nearly 40 years. I'm also an Air Force veteran, proudly served the nation in the medical arena in the global war on terror and overseas operations after 9/11. So as a doctor and as a veteran, I have some experience with physical and emotional trauma. I know the signs, what to look for. It's my opinion, 2 years into this tragedy, that our nation is suffering a type of battle fatigue from our long fight with COVID. And the full impact of this pandemic on our national psyche may not be known until long after this difficult period ends. And it will end eventually. We are seeing many states lifting public health mitigation measures such as indoor mask wearing. And while this represents a new phase of the pandemic, it's critical that such important decisions about public health are rooted in science and data and not driven by political pressures. Every one of us is eager to bring this painful chapter to a close. But how we emerge from this pandemic, the lessons we learn and apply moving forward, the causes we fight for, will go a long way toward preventing the next great health crisis from gripping our country. Our actions now can reshape our U.S. health system to better meet the needs of all people, not only the brave men and women in the medical workforce, but everyone who relies on our health system for the fulfillment of a long and healthy life. COVID-19 will be with us for the foreseeable future, and we must understand what that means and make every effort to protect the most vulnerable among us. That means becoming fully vaccinated against the virus and receiving booster shots when you're eligible. It also means vaccinating our children when they are eligible. I encourage anyone with questions to talk to their doctor or another trusted health professional about the safety and efficacy of COVID-19 vaccines. We really must do everything within our power to protect ourselves and those close to us as this virus evolves. If we do that, we'll ease the extraordinary pressure on the frontline workers in our hospitals and make it easier for everyone to receive the medical care that they need. Whatever this new normal looks like at the end of this pandemic, we should all agree that it can't look like it does now, where the hospitals are consumed with those needing care for COVID-19 and might even be pressed to limit care for patients with other diseases. That simply cannot happen. Let's talk about what we've learned during the pandemic and what needs to happen to create a health system that honors those we have lost to COVID-19 and better prepares our nation for whatever comes next. This work should start with a focused and comprehensive effort to rebuild trust in science, in medicine, in government, and in the public health agencies we rely on for credible, evidence-based information. Sadly, COVID-19 isn't the only pandemic we're fighting in America right now. The other pandemic is a profound loss of trust in the advice of experts, including doctors and other scientists, to help us make sense of what's happening and to make informed decisions about our health. This pandemic of mistrust was probably coming and beginning a little bit before COVID-19, but the extreme polarization during this crisis has just profoundly hampered the nation's ability to respond. It's a major reason why the U.S. has a far higher death rate from COVID-19 compared to other similarly resourced countries. There have been numerous and well-documented missteps prior to and since the start of the pandemic that have understandably contributed to this environment of distrust. Inadequate funding of pandemic preparedness and public health agencies, unclear lines of responsibility, uneven use of federal authority to produce masks and personal protective equipment, as well as testing and supplies, mixed messaging on masking, social distancing, isolation and quarantine, political and sometimes even personal attacks on scientists and physicians. And most recently, an inadequate response to the Omicron surge with a shortage of testing more than 18 months into the pandemic. Playing the blame game right now is going to be an exercise in futility. But we do recognize these missteps. Our focus now ought to be learning from those mistakes and rebuilding the lost trust as a result. One way to begin rebuilding trust in science and medicine is to effectively counter those voices who spread easily disproven and blatantly false information online. Surprisingly to me, some of the loudest purveyors of misinformation and junk science during this pandemic have been a very small number of doctors and health professionals. These offenses are, in my opinion, among the most egregious of all because they violate the ethics of our profession, and each lie and untruth spread by the click of a mouse erodes the trust that is at the very heart of the patient-physician relationship. Trust that is essential to our ability to provide care. That's why the American Medical Association has called for state medical boards to respond swiftly when physicians spread falsehoods online and through the media, particularly disinformation related to COVID-19. It's critical that state licensing boards do their part by stepping up their vigilance for this kind of behavior. It undermines public health and vaccine confidence. What's more, we strongly encourage policymakers to explore appropriate methods of limiting the spread of disinformation and ensuring there's accountability and consequence for those who do so. Similarly, the AMA urges media outlets, including influential social media companies and streaming devices and services, to remain vigilant, to help their readers, their viewers, and the listeners to more easily separate fact from fiction and reduce misinformation. And this can be accomplished while upholding the principles of the First Amendment that we all hold dear. We continue to call on our public health agencies to base decisions on scientific evidence, on data, and on equity. And for our government scientific institutions, now and in the future, to be led by experts in their fields, not by political agendas, and for the actions made by our government leaders to be guided by the best available evidence. We all must work to reassure the public that the information they hear and read is reliable, that it is rooted in science and data, and that they can trust it with their lives. Today, the AMA is calling for 5 specific actions to fix our ailing health system, to rebuild trust, and to better respond to the next public health emergency. And there will be one. The first, we'd like to enhance our state and federal stockpiles of medically necessary supplies and improve the system for acquiring and distributing them. The shortage of PPE and other essential supplies in the early months of this pandemic slowed the country's response and needlessly put lives of physicians and our frontline healthcare workers at risk. Given what we've experienced in the pandemic, global demand, we know, can quickly outpace supply for even simple items like cotton testing swabs. That should never happen in a country like the United States, as rich in resources and manufacturing as ours. We're calling on Congress to work with federal agencies to build our domestic manufacturing capacity, utilizing public-private relationships and partnerships to quickly accelerate production. We urge that the nation create a transparent plan for obtaining and distributing personal protective equipment and other needed supplies with clear delineation of federal and state roles. And we call for increasing funding and improving planning for the strategic national stockpile, creating contingency plans and providing federal guidance on what needs to be stockpiled and what should be provided to states and local entities in a crisis like this. Second, we must significantly increase funding to bolster the nation's diminished public health infrastructure. Chronic disinvestment in government public health agencies puts lives at risk and has severely limited our ability to fight COVID-19. State public health spending has dropped 16% over the last decade, resulting in the loss of nearly 40,000 jobs at state and public health agencies. It's gaps like this that at the community level contributed to a lack of widespread testing, resulting in a more virus spread in the early stages of the pandemic. And our lack of an ability to perform large-scale genetic sequencing allowed for dangerous new variants to spread, sometimes without detection. A robust public health infrastructure is our nation's best defense against infectious disease. It's critical that we invest what is necessary to increase staffing, upgrade essential functions, such as public health surveillance, which would make it easier to respond to emerging threats and to better educate the public how to protect themselves in a crisis. Third, we must learn from the process that led to the rapid scale development and production of several safe and highly effective vaccines. Operation Warp Speed is, quite simply, one of the greatest scientific achievements of our lifetime. We believe the public-private partnership and operational structure of this plan should be preserved in some form for future pandemics or any time vaccines and therapeutics are needed in such an emergency. Fourth, the rapid expansion and integration of telehealth and remote patient care has been a lifeline during the pandemic, not only for patients but for struggling doctor offices that were during practices in periods of intense lockdowns. The AMA has long championed telehealth and has provided expert guidance, support, and resources to help physicians implement it in their practices, especially during the pandemic. But for telehealth to succeed the way patients and physicians need it to, we need the help of Congress. The AMA strongly supports the Telehealth Modernization Act and applauds the inclusion of it in the Second Cures Act. For the rest of the pandemic and beyond, Medicare patients must retain the ability to access telehealth services from their doctors without arbitrary restrictions. And finally, we must pause to consider the extraordinary pressure our physicians and healthcare workers have had to shoulder the last 2 years. Men and women on the front lines of our emergency departments, our intensive care units. They've gone above and beyond in their service to all of us. They've worked extremely long hours, often for days at a time, through every surge, at great personal risk to themselves and to their loved ones. I promise you, I've personally been there as recently as this past December. Far too often, and with increasing frequency, they've also become targets of violence and intimidation from an angry and equally anxious public. This can't be our future, and it shouldn't be our present. We owe physicians and healthcare workers a whole lot more than just our love and appreciation. We owe them our sincere efforts to fix the problems that have plagued our response to COVID-19 and to work with them to solve common frustrations that are driving so many out of the profession. As a nation, we've begun to open our eyes to the mental health needs of physicians and healthcare workers. The AMA commends Congress for passing the Healthcare Provider Protection Act. This legislation, named for Dr. Lorna Breen, the New York City emergency doctor, who sadly took her own life in 2020 after weeks of intense and psychologically grueling duty providing care for many COVID-sick patients in her Manhattan hospital. This Provider Protection Act will help raise public awareness of the mental health needs of physicians and dedicate federal resources to create evidence-based programs to better support physicians and other healthcare workers. This type of action is long overdue. You know, an article in December in the Mayo Clinic's Medical Journal confirmed some of our worst fears about what this pandemic and other stressors are doing to our healthcare workforce. The report was based on a broad survey of medical professionals this past year. And it showed that 1 in 5 doctors said they plan to leave their profession within the next 24 months. And many more have planned to retire or reduce the hours they've worked. The reasons they cited would be familiar to anyone who practiced medicine today, including a long list of administrative burdens and an overly bureaucratic system that leaves physicians feeling pretty powerless and removed from what we do best, which is providing care for our patients. And some of these problems, like others I've mentioned, existed long before COVID-19 pushed many of us to the breaking point. Our nation needs a hard reset on how we nurture and grow our physician community, with an eye toward increasing not only its size, but its diversity. We need to expand the number of residency training slots for medical students and to remove caps to Medicare-funded positions to bolster our physician workforce. We need to address and alleviate one of the largest barriers that keeps more bright young students from pursuing medicine, which is the exorbitant cost of a medical school education. The average young doc in the U.S. leaves medical school with almost $200,000 in debt, which sometimes drives them to seek higher paying positions in larger cities and contributes to physician shortages in rural areas like where I live. We must build a better education infrastructure with pathways to encourage more young men and women from a diverse background to pursue medicine as a career. Almost 1 in 3 people in the United States come from historically marginalized communities, but fewer than 1 in 8 are doctors. This has to change. The AMA has spent nearly a decade convening leading medical institutions through our accelerating change in medical education and reimagining residency initiatives. We also have a number of efforts underway to increase physician diversity, including through scholarship assistance, mentoring, and other pathways. But here too, we need a concerted federal effort and resources to make that a priority. That's why the AMA urges Congress to provide appropriate funding to support the creation and sustainability of medical schools and residency programs that have their roots in educating diverse populations, including at historically black colleges and universities, Hispanic serving institutions, and tribal colleges and universities. To meet the unique challenges of healthcare in the 21st century, it is essential that we build a physician community that better reflects the growing diversity of our patients. No amount of planning or investment that we can make can completely eliminate this next viral threat. But America is blessed with tremendous resources. We have the best trained, the best educated, the best equipped doctors in the world. We are brilliant, pioneering researchers pushing the boundaries of science. And after 2 years fighting COVID-19, we have a renewed sense of ourselves, the communities in which we live, what we must do to rebuild trust, to create a health system that is more inclusive of diverse populations and their needs, that's more accessible to all, that's more supportive of physicians and healthcare workers. It's more flexible, better able to respond in a crisis. We have no choice but to learn, to grow, to change, and to adapt to the health threats that are inherent in our increasingly connected world. We've come too far as a nation not to learn from the past 2 years. Now it's time to act worthy of ourselves. Jen, I thank you.
Thank you so much for those opening remarks. Want to dive right into questions. After 2 years of COVID, do you now believe that we should rip up the public health system and start all over again?
No, I think that would be a pretty impressive move, but I don't think it would get us anywhere. We're not willing to trash it. What's been for centuries or more a pretty good system. We just have let it kind of lie a little fallow. We need to fertilize that field. You know, we forgot that we needed crops to grow on it. We were doing so well without a pandemic to drive us that we kind of pushed it in the background. The public health system, like a lot of public infrastructure, when it's working, you don't know it. When it's working well, you don't really know it. You don't really worry about the electric system or the water system until you don't have it. All of a sudden, how do I get the power system back on? How do I take care of my water and things like that? So the public health, a good high-functioning public health system, hums along in the background. But it has to be resourced. It has to be prepared. We have to be prepared for the next viral threat, the next public health emergency. And as you heard me in my opening remarks, it will come. Mm-hmm. It'll happen again. We just need to learn from what we're doing, build upon it, resource it better, and take these learning points that we've just made and the actions that we can build upon and execute them.
Mm-hmm. For this pandemic, do you obviously I think we were caught flat-footed, but were doctors prepared for this pandemic? Was anybody really? But talk about the level at which doctors were prepared for this pandemic and where it sort of fell short.
Well, Jen, I just mentioned, I think we probably had disinvested in our public health resources. So we didn't have a lot of doctors aggressively pursuing the public health infrastructure. They were, I wouldn't say they were floundering, but they didn't really get the support they should have from administration and government and legislation, and perhaps even some of the healthcare system itself. And so we were prepared, let's say training-wise. We had the training, we had the education. Science is rolling right along. We're always a continuous learning profession, so we like that. But we probably didn't have the focus, and I know that my offices and our healthcare system didn't have a backup of personal protective equipment. We had what we anticipated would need for minor outbreaks of various infectious diseases, but we didn't know we'd be going through such a rampant need of personal protective equipment, full masking, gowns, things like that. And so the doctor's offices were probably as prepared as they could be. You got to understand, we think there's a public health infrastructure too. It's not like we had a bunch of testing supplies because there weren't any tests developed. So I don't think the doctor's offices per se were caught flat-footed. I think the entire infrastructure that we kind of assumed was working as well might have let us down a little bit.
Okay, all right. Do you think, after this, that doctors are now prepared for the next pandemic? I mean, training-wise, but also resource-wise. Do you see things getting into the right positions for, preparing for something like this if it were to happen again?
Jen, I'm a pathological optimist, so I know we're better. Okay, yeah,
we all are.
You fool us once, shame on you. Fool us twice, shame on me. So we're getting more prepared. We really do. I think we're much more aware of the need for preparations in our practices. But to my comments also, we're also concerned about a workforce shortage. We're concerned not only about the physician shortage, but nursing shortages, pharmacist shortage, technician shortage. Folks entering the healthcare profession as an entire profession we now realize there's a substantial shortage of this, and there's a backlog of training opportunities. I mentioned graduate medical education. It takes a long time to generate a workforce in healthcare. It's not like a 6-week training program. It takes months or years to prepare one for many healthcare specialties. So we've learned that we need to do more for that too.
Okay. How bad is the Great Resignation impacting doctors now? How many are we going to lose to burnout, and in what specialties and subspecialties? And how and when and where do you rebuild the medical workforce? I know you mentioned that there are many doctors who say they plan to leave in the coming years. So talk a little bit about that problem.
Well, Jen, that was a problem that was existent even before we had the COVID accelerator, let's call it. Okay. So we've had a workforce issue placed on steroids by the COVID pandemic last 24 months. We already had one of the number one frustrations for physicians was barriers to care. That's one of the things AMA has been using as a strategic arc, is reduce barriers to care. We want to remove obstacles to patient care because, as I mentioned, we're all about taking care of patients. That's the greatest physician satisfier, is getting appreciated by my patients, know that I've helped make them a healthier person, prevented the onset of a critical illness or disease, and my reward is it's really felt in the heart, as it is many physicians. So we're already frustrated that the barriers to care, the electronic interfaces, not just electronic records, but all the pharmacy or the prior authorization requirements, the dissatisfiers that don't add to patient care, detract. So we're already there, and then you put the COVID pandemic on top of it. And a lot of folks, as I mentioned, 1 in 5 doctors have indicated they're going to certainly in the next 24 months they're leaving, and many more reducing the hours. We are trying our best to make sure we prepare more medical school graduates with graduate medical education slots. We're encouraging people to improve not only the number, the diversity of physicians. And I think what we're going to find is that if we can re-energize, and we're working at it, a conversation like we're having today, if we can re-energize an interest in healthcare among this highly talented pool of pre-medical students out there, we'll get them engaged.
Okay, just to sort of pull the thread on that a little bit more, obviously the AMA supports increasing the number of physicians. So what policies or processes are making it harder to get there now? What else is causing physicians overall to stay at these lower numbers than our society needs?
Well, other than
the frustrations. Yeah.
Well, other than the frustration, the length of training does wear one out sometimes, and we have to remember that physician health goes all the way down to the medical student and level, because they're getting discouraged too. They were not able to educate standard training procedures recently, so they're having to relearn how to be educated. But the other things that I think frustrates us as doctors is not only the bureaucratic workload, but we're starting to see a little lost trust, the pandemic of distrust that we talk about. So we're going to have to make sure we package ourselves, that we engage our patients and make the patients the focus of what we're trying to message. And we have to have shared decision making is one of the discussions we have at the AMA, where we educate not only ourselves but our patients about why we're giving them good advice, why they can trust us with their lives, as I talk about. And we're working hard with that. I mentioned we have to look at Congress. Right now we're struggling, the AMA and physicians, with what we call a physician payment structure. You know, part of the issues we're finding with physicians is not only impediments to care, but we feel that we're being kind of reduced and not appropriately allowed to be paid for the work we're doing. Physician payment structure is based upon an outdated, archaic provider payment system. Physicians, we have data that shows that physicians have lost ground over the last 20 years because we have what's called a revenue budget neutral physician payment system. Pharmaceuticals can charge more money and get paid for it. Hospitals can charge more money and get paid for it. Our various manufacturers can charge more money as the cost of medical care, and it will go up. It is going up, not so much because of a shortage of doctors, but because of new technology and a growing burden of patient disease, chronic disease. Everybody is living long enough to need more and more medical care, and we're, thank goodness, seeing it. We're getting healthy lives and into the 70s and on. Mm-hmm. But physicians have are the only part of the healthcare payment system that's capped, and it's been capped. If we had not acted and Congress had not responded as of this past January, we'd have had a 10% pay cut, on top of the already economic hardships physicians and practices have entertained over the last 2 years. Well, that's unthinkable. So at least Congress delayed it. We appreciate that, and they're very receptive there. But we've got to fix this ailing healthcare system so the doctors are encouraged they can reduce that medical school debt I talked about and be able to sustain their practices. Otherwise, even if we put people in the system, they're not going to be able to sustain it.
Mm-hmm. How are you working to help to reduce the cost of medical education now? What are some of the things or initiatives that you're looking at doing to, so that doctors don't leave school with $200,000 in debt?
They're leaving school with a mortgage without a house. Right, if you think about it, goodness gracious, they're not really homeless yet, but they can't afford a home because they got to retire that debt. Mm-hmm. Well, clearly what we're looking at is loan forgiveness. We're looking at a lot of scholarship and grant supporting medical students to get into school. We're looking at loan forgiveness. We're getting tax incentives for folks that stay in underserved population areas, that choose underserved populations and underserved specialties. As I indicated, when physicians, medical students graduate, they look for residency slots that not only appeal to their clinical interests, but also would allow them to retire their debt so they can be sustainable. We talk about physicians' mental health. They're already making incredible sacrifices. Mm-hmm. They put off getting a job for 4 years of college, 4 years of medical school, 4 to 8 years of residency. So they double their education before they can start earning a living. They've already made a lot of sacrifices, and they're supported by a very enabling family. And a lot of times, those in healthcare families know that the family support structure is so important. So everybody makes sacrifices to allow the goal of becoming a physician to become a reality. And then they try to service that debt. So they're going to go where there's a job opportunity, an economic opportunity. So we're trying to make sure that those who want to be primary care specialists, who want to serve in relatively uneconomically challenging fields like public health, they'll be rewarded, not only in their soul and in their heart, but allowed to maintain their practices. That's what they're after, and we can make that happen.
Okay, great. Can you talk a little bit more about what that looks like to be rewarded for working in obviously it is rewarding, as you said, to work in communities where, they may not be making as much money, or, it's a little bit tougher to have a practice out in rural areas, as you've said yourself. So what do incentives look like there?
They look like tax incentives. You don't have to pay as much taxes. You get tax credits. You get loan repayment, loan forgiveness. That happens. You give a scholarship, sometimes the communities, sometimes the areas themselves, make it available to help fund the tuition of those students. Medical schools have numbers of programs also that they'll have scholarships available for their graduates because they want to serve the communities too. That's why the medical schools are out there. The academic centers are doing a good job not only research, but providing the workforce that we need in the 21st century. That's part of the AMA's mission as well, the academic mission. So they are seeing that, and we have a number of legislative bills we can help advocate at the Congress level, at the state level, so that you can have some state and local funding opportunities. And there are real numbers, not just, as I said, our love and affection, but economic reality and some hard numbers that will help them.
Okay. I'd like to dive a little deeper into the Healthcare Provider Protection Act that you mentioned, if we're talking about burnout and the mental health of our doctors, particularly as COVID wears on everyone. What does this do, and where is it in the legislative process at this point? Is it passed?
It has not been signed into law by the president yet that I'm aware.
Okay.
I know it has passed both houses. It's a bipartisan support legislation, but it's not signed in the White House, by the White House yet. What it will do is it allows healthcare workers and including physicians, nurses, pharmacists, anybody in the healthcare field to access healthcare resources, to make sure that their insurance pays for it, to make sure that they are destigmatized from seeking health care when they need it in an emotionally charged time, that they are not held inappropriately accountable for reporting or seeking health care. One of the issues we're concerned about is that as doctors, as healthcare providers, we're almost afraid to admit we're worried, we're scared. We have to have this impenetrable armor.
To put on a brave face.
Yeah, put on a brave face. And I tell you, we all do that in front of the patients. When we're in there with the exam room with the patient or the hospital bed or wherever we work, whether we're a nurse or pharmacist or lab tech drawing the blood, we're absolutely focused on what's going on with the patient. We leave everything else at the door. They need to know that. But that doesn't mean we can totally compartmentalize it. And when we know we're having time focusing, we know we're going to say, hey, I've got to go talk to somebody. I've got to seek some guidance about my behavioral, my emotional, my mental health. That they're not stigmatized. They're not then put into some parking area where they're not allowed to practice their art. So we want to make sure that's protected. We want to make sure that that's covered in all the healthcare plans. And there's a recognition that it's not a sign of weakness, it's a sign of need that also strengthens our ability to deliver health and deliver safe care.
Okay. Switching gears slightly, the AMA has advocated against the mistreatment of healthcare workers throughout the pandemic. Why do you think these threats and violent acts are steadily increasing? And what can healthcare organizations and hospitals do to prevent this?
That's serious. It really is. I've been in the combat theater where you take care of the enemy, as it were. You take care of who's going to defend you, and then you work down. But we've taken care of folks that if we didn't restrain them, they would attempt to harm us. So it's very awkward to do that, but it's part of the healthcare profession. We take an oath to deliver care to everybody, and we do that. And healthcare workers are doing their jobs. They're out there putting their health at risk, as I mentioned. In an infectious disease environment like COVID, they can get sick. We know that, and it's a serious disease. It's not just a runny nose or a cold. It can have lifelong consequences, if not fatal consequences. So when we healthcare workers are out there doing it, I know there may be some, or apparently there are some, who are already worried in public. They're already stressed, they're anxious. I mentioned a pandemic of mistrust and misinformation that we're fighting. They need to step back and not get in the way of healthcare workers who are just doing their jobs. They may have an opinion, they may have their First Amendment right, but they don't need to be threatening, either verbally, physically, or in any way threatening the health or the safety of our healthcare workers. That's untenable. We can't allow that to happen. And there's also been some racial undertones to it. There's no question of that. And that's also something that we're not going to stand for at the AMA. Not only for doctors, but any healthcare worker. When they're out there doing their jobs, for goodness sake, don't threaten them. Don't get in the way, because they're trying to take care of your loved ones. They could be taking care of somebody in a demonstration line who gets hurt. Guess what? They're going to give them health care. Think about it.
Yes. Let's talk about medical misinformation. You mentioned this in your speech. It's been the hallmark of the pandemic. This is a problem not just in the medical world, but what can the medical industry do at this point to help with the misinformation, disinformation problem? And in addition to that, you talked about how some doctors are participating in this. So should more doctors lose their licenses or board certifications? What do you think should be grounds for disciplinary actions against doctors spreading misinformation, and what can policymakers do to deal with that?
Well, that's very, and I did mention it because I mentioned how serious I interpret it, because once you injure that trust, once you injure the confidence, the faith that the public has in us as a healthcare profession, then you start to degrade the entire civilization. You really do. Once you can't believe what your doctor is saying, then who can you believe? If you think about it, you got to have somebody to trust. So I would tell you that I wouldn't say that a doctor needs to lose his or her license, but the licensing boards, the regulatory bodies, in most states, physicians, of course, there's a medical board, but some of the states, it might be a board of pharmacy, it might be a board of dentistry, a board of nursing, so we can hold accountable those who deliberately spread obvious misinformation and what I would call disinformation. Not only this misinterpretation, but deliberate misrepresentation of data or what they would like to have to advance their political agenda. That does bother me, and I think you don't necessarily have to have the medical boards. I don't need to dictate. The AMA doesn't need to dictate to the medical board what punitive action or any disruptive any action they should take disciplinary-wise. It doesn't have to be so far as to just immediately lose their license, but they need to be held accountable. What happens now with most medical boards, if there's an essence of something that seems to be outside the standard practice, there is a notification of the physician that, hey, we need to have you come to explain yourself, what's going on, give your perspective of the story, and then we're going to decide if there's a regulatory discipline. They might suspend their license for a while, they might put them on probation, but there's some accountability for deliberate misinformation that's clearly outside the mainstream of medicine and research and data and science. And the same thing applies to not only the medical boards, but the policymakers. When you're looking at putting someone on a show, or you're having some science or some show that's apparently, maybe it's a broadcast, maybe it's a podcast or something, if you're the medium or the sponsor of that, you need to think about what messages you're delivering, and is it really harmful to the public good? Mm-hmm. So I think that's where policymakers, and that's not where a regulatory body like the AMA, like a medical board or the AMA can insert itself, but certainly the policymakers and the regulatory agencies there can think about it. Do we need to be a purveyor of mistruths and deliberate disinformation?
Okay. I wanted to ask you about warp speed. You spoke very highly of that. Can you highlight some of the things that stood out to you that you'd like to see applied in the future, that warp speed?
Well, it's interesting. Well, it's interesting. I'll tell you that when I first thought about it, if you think about it, we basically shut down a lot of American economy in the middle of March 2020. And again, as I introduced in my comments, the first deaths to COVID in the U.S. were in February of 2020, 2 years ago this month. That was a herald of a bad time in American society and American medicine. So in March of 2020, we didn't understand much about this disease. We didn't know how contagious it was. We know it was starting to spread pretty rapidly, kill people, make them really sick. We didn't have any treatments. We didn't have any diagnostic testing. We sure didn't have a window of vaccine on the horizon. And then by the end of that year, I was vaccinated. You understand? I mean, I was in December of 2020. I had a vaccine in my arm as an older, higher risk citizen, but also as a frontline healthcare provider. I'm thinking, that's a modern miracle. I mean, it really was. And what stood out for me was that the reasons we were able to do that so rapidly was not because of the science. It wasn't because the science was held up. It wasn't because the actual testing of the FDA, the CDC approval processes. It was because the administrative bureaucracy was compressed. All the scientific hurdles were still intact. Nothing scientific was missed. But all the debating about, do we fund this? Do we have to appeal for this grant? Do we have to have funding and budgeting? Does a board have to meet to oversee the disbursement of funds? That was the compression of time. And that's something that's really never happened before. There's always been a budget or funding hurdle, short of maybe World War II with developing bomber technology or something. But this is an incredible modern miracle to be able to develop an effective and incredibly safe vaccine with 90% responsiveness on some of those vaccine trials and developing antibodies. Who'd have thunk it?
Does this teach us that we can be moving faster even if we're not racing to solve a pandemic in terms of, vaccine development or some other things that Warp Speed did in terms of responding to the pandemic, testing for certain diseases at home, things like that? What are your thoughts?
It really does. I mean, we have the technologies I talk about, and the bureaucracy gets in the way. I already mentioned how much that is dissatisfying to physicians that, hey, I know how to do this. I know what my patient needs. I know the x-ray test my patient needs. I know the surgery. I know the medicine my patient needs. But I had an example last week where my 90-year-old mom changed insurance plans, and now she's got to go through a prior authorization process with step therapy on medicine she's been constantly stable on for 8 years. So that's an administrative burden that doesn't have to exist. It puts the health of my mom and 90-year-old patients like her and many patients at risk. So yeah, the frustration of bureaucracy getting in the way of the science and the data is very real to us as doctors and a dissatisfier for sure. Maybe we should learn as a society, and we need to learn as a profession, that some of the bureaucracy is needed. I mean, you have to have regulation, no question. You have to have funding and resourcing. But really, it can be compressed and still have a great benefit and get us a whole lot faster to where we need to be.
Okay. I wanted to ask just a couple more questions, and then I'll jump over for a few questions from our audience that's streaming in here. You talked a little bit about telehealth, and that's something that's really become more commonly used in the pandemic, and you worked, I think, through a lot of the kinks there, but you mentioned that Congress, they're working on a Telehealth Modernization Act, if I'm saying that properly. What does that do? How does that improve the telehealth process in terms of where it is now and where it could be going in the future?
One of the things we learned, Jen, during telehealth, or during the COVID pandemic and the public emergency, was that we could use telehealth in an effective manner. The data now shows that we can do pretty good health care with quality not really compromised too much for some of our telehealth visits. That patients in rural areas and geographically separated areas, sometimes even urban areas without ability to access a local provider, if they can get on a telephone, if they can get on the internet, if they can get on some type of electronic medium, they can communicate with the healthcare provider, discuss their symptoms, get a diagnostic plan set forward, and get treatment just with a telehealth visit and not a compromised patient care. Now, what we also found is that it still has substantial cost associated with it, so we need to make sure it's compensated fairly. But most importantly, one of the most important things we found out about Medicare and the Telehealth Modernization Act is that patients before the Telehealth Modernization Act and before the public health emergency with the relaxation of some of these guidelines and administrative burdens we talk about, patients had to go to some special location to access care. They couldn't just do it from the comfort and safety of their own home. They couldn't just either do a digital visit or a telephone visit with their doc because that didn't count. They weren't allowed to do that. That was not considered to be right. We know that's right now. So now patients can do that from the comfort and safety of their own home with the passage of the Telehealth Modernization Act and still get care. Now, it won't get rid of in-person visits. You can't fix a broken arm over the internet, okay? But you can look at rashes. You can say, are you feeling better? You can get your what we call telehealth diagnostic blood pressure, blood sugar, home oxygen levels measured, and get advice that way. It is hard to sew up a wound over the internet without getting in person. But chronic disease management can be extremely well advantaged using telehealth.
Well, I had a baby in the pandemic, so I did use a little bit of telehealth.
And that's another digital. We understand that telehealth in maternal fetal medicine is another win because you're not sure about what the baby's rash looks like. You're not sure, but if you give me a picture, and I'm as a family medicine doc, I still take care of pediatric patients. I can look at that rash and say, oh, I know what that is.
Yes.
Oh, you got to bring that baby in now. All those things make a big difference, and it's incredibly rewarding and reassuring when you've had your doctor look at the same rash you're looking at.
Yeah, it was wonderful to use that process. At the end of your speech, you said, now is the time to act worthy of ourselves. What did you mean by that, and how can we do that?
Well, it's pretty serious. I borrowed that term from a Revolutionary War doctor. There's a Major General Warren, Joseph Warren, who was killed at the Battle of Bunker Hill. He was a ranking officer who died at the Battle of Bunker Hill. About a month before the Battle of Bunker Hill, he was a Major General, 2-star general, a physician also. He was well thought of, and he was an unusual general officer leader in that he was always going to the forefront with the fighting soldiers. He wanted to be on the front lines. And he gave a speech about a month before the Battle of Bunker Hill, and he said, and he was encouraging his troops to go out there and do their best, and he said, "Gentlemen, we embark today on a battle that will our actions today will impact the lives of generations of Americans yet unborn. Let us act worthy of ourselves." And I'm thinking, gee, that's what we're doing now. That's what we're doing in American medicine and healthcare, and indeed in the American citizenry. Our actions in this pandemic will reflect and have impact on generations of Americans yet unborn. I consider it very important and a privilege to be able to act worthy of ourselves.
All right, thank you for that. I'm going to jump over and ask a question coming in online from club member Bob Weiner. What is the best way to break through the politics and persuade the many anti-vaxxers on the numbers showing the vaccination health and mortality benefits they insist on denying? And isn't this the real crisis, that no one has found a way to persuade this large population bloc? Maybe you have the answer.
Well, Bob, I already have the descriptive answer. It's not just a pandemic of COVID, it's a pandemic of mistrust, a pandemic of lost trust, a pandemic of disinformation. So recognizing that that is itself a pandemic, as he describes, it's more than just a virus. Somehow we need to re-engage our public and get them to trust us, to know that the reason we're in it is for their health only. That is a challenge. What I do this daily, and I run into anti-vaxxers or people that are vaccine hesitant daily. And I'll call them out and I'll say, and not embarrass them, but I'll say, "Hey, what questions do you have that I can answer?" "Well, Dr. Harmon, I'm worried about my fertility." No, you don't need to worry about it. Studies show they won't do. In fact, if you're contemplating pregnancy, you should get vaccinated because your baby will be healthier if you don't. You trust me with other things. You trust me with your heart. You trust me with your decision about cancer therapy. For goodness sake, trust me about this. Trust somebody, a healthcare provider that's earned your trust before. We need to one-on-one. It's hard to do it any more broader than that, but we need to face the facts, tell them we are trusted, we continue to earn that trust and respect that trust. It is really challenging, but that's a pandemic itself.
This question comes from Amy Fickling, also a club member. Did the pandemic help us learn anything about the state of health of Americans? Any statistics being kept during the pandemic that would indicate Americans are generally in good health, but the COVID-19 disease is non-discriminatory when it comes to general health? Or can you think of any statistics out of the pandemic that would point to Obamacare having meant that more people who got COVID-19 had access to care?
Well, that's a very broad-based question, complicated. The simplest answer I can give you, Amy, is that we were already facing a loss in life expectancy before we had COVID. You might have seen some statistics that were reported where we had lost a year of our life, a year of life expectancy, even before we got into the 2020 COVID year. So that was concerning to us. The COVID year in 2020 did show us that we lost another year of life expectancy. So that was concerning. I think that we're already starting to have some problems with chronic disease. That's one of the things that we take up as one of our strategic arcs in the AMA, is advancing the art of medicine but the betterment of public health. But we really we're already focused on some problems with American health. So that was concerning to us. Well, we also found that unfortunately disproportionately impacted were persons of color, with the average American losing a year of life expectancy during the COVID year, but those who were black or brown patients were losing 2 to 3 years of life expectancy, respectively. So they were disproportionately impacted during the COVID year. So that not only did we find that we're losing health care for all Americans, we're losing disproportionately for certain marginalized communities, and that was really concerning to us. So we need to address that. That's the reason I think it's now, as I said, time to act worthy of ourselves to address these needs of public health issues and raise health equity and address health disparities.
Okay. Club member Joyce Frieden, Washington editor of MedPage Today, asks, you talked about the loss of trust in scientists and doctors. The CDC has been criticized for flip-flopping on some recommendations and deciding some things too late. What could the CDC do to restore trust and be more effective?
Well, the CDC needs to be more consistent. I think you've heard me take a public stance on that some time back when they issued a statement that said you can go back to work or school after 5 days without a test, even though you were sick and known COVID positive. And we had to step forward as a spokesperson for American medicine and public health and say, we think you need to have a negative test, or you need to wait a little bit longer before you go back release yourself back into the wild and contaminate others, with data showing that even 31% from the CDC's own website, 31% of those at 5 days were still contagious and shedding virus. That bothered us a little bit. Yeah. So the CDC, and they're like everybody else though, they're healthcare professionals, they're scientists, they want to open America back up, they want to get people back. They're as anxious as all of us, they're humans, and what they did was motivated, I think, for all the right reasons. I think that they are absolutely following what they are being driven by, what they're driven to recommend by the science that they're interpreting, by the data they're receiving, and they're a really good filter of the data. I trust them. I don't have the CDC expertise. That's why they're the CDC. That's why they're NIH folks. That's why they really are the experts. And there are going to be some disparate opinions on it, but on balance, I trust them. They continue to be very good researchers. They continue to have our best interests as a nation and individually at heart. If they continue to do the right thing, they'll gain their trust. One thing I'll say, one of my quotes that I used to use in the military, and I still use it now, is the best way to overcome organizational resistance or lack of confidence is to continuously demonstrate overwhelming competence. As long as they continually demonstrate and continue to do that, to try to demonstrate overwhelming competence, they'll wear down the naysayers and the lack of trust.
Okay, thank you. We are out of time for questions from the audience, but so before we wrap today's discussion, let me take a moment to thank Headliners co-team leaders Donna Lyman-Legere and Lori Russo, the Headliners team member who assisted with today's event, Aaron Cohen, Club Membership Director Kate Helster, and Club Executive Director Bill McCarran. And now for our last question, are you Team Moderna, Team Pfizer, or some kind of combination of the two?
I'm for team vaccination. That's what I'd like to see. I really would. If you can get vaccinated, I've got 8 grandkids, 7 of them are eligible for the vaccine. They've all been vaccinated. My children have all been vaccinated. My immediate family members, my 91-year-old mom has been vaccinated and boosted. I appreciate you and the Press Club being a purveyor of the truth. Y'all mean so much, and you're part of the answer to the pandemic of distrust. You help improving trust in American medicine. Thank you.
And when do you predict a toddler vaccine will
well, it's
be
pretty
available?
Close. I mean, if you think about it, vaccines to that point are still being developed at times. We've changed vaccines over the years. We used to have 1 shingles vaccine, now we had 2. We thought 1 chickenpox was enough, now we know we have to have boosters. So vaccine technology, vaccine science, it's science, it's not math, it's not always fixed, it's an evolving science, and data tells us what to do. I think you'll find a toddler vaccine down to the age 2 and up pretty soon. Research is there, and I think it clearly indicates that it's needed because most of the virus right now, infected kids are below the ages of 5. Mm-hmm. They're the ones that are being hospitalized because they're not able to be vaccinated.
Exactly, and I have a 3-year-old and a 1-year-old at home, so I'm sitting on the edge of my seat waiting for that toddler vaccine. And before we close this morning, I'd like to thank Dr. Harmon and the American Medical Association for joining us today, and to present you with the coveted National Press Club mug. Thank you again for joining us.
Very meaningful. I'm honored to be here and to receive it.
So glad to give it to you in person.
I'll keep it.
All right, thank you.